All right. Hello, good afternoon, everybody. Welcome to our Antibiotic Stewardship Echo Clinic for the day. So glad you all could join us. Great turnout for this session, so thanks for being here. So I'll start off for those of you, I see a lot of new names, so I just want to give some background on what ECHO is. So Project ECHO is a telehealth program offered through the University of Nevada, Reno School of Medicine. And what we do is we put together multidisciplinary teams of specialists and hold video conference sessions like we're doing today for providers throughout the state to get support with your patient cases, any challenging cases that you have that we can help you with. And then we provide didactic presentations on any number of topics. And just want to be here to support you in your practices all across the state. So we'll start off with some quick introductions. I'm Troy Jorgensen. I'm the program manager for Project ECHO Nevada. We'll go out to our hub team today. So Dr. Krasner, you want to go ahead?
Hi, this is Joey Krasner. I work for the university and the VA hospital. I do infectious diseases.
Thanks, Dr. Krasner. And Jessica?
I'm Jessica Thompson. I'm one of the infectious diseases pharmacists at Renown Health.
All right. And Dr. Levy?
Hi, Mordechai Levy here, medical director here at Project ECHO.
And then Sneha? Just a second, Sneha, we'll unmute you there. Go ahead.
Hi, this is Sneha Sharma. I'm the program coordinator for Project ECHO Nevada.
All right. So that's our team and our hub team for the day. With such a large group, we won't have you all introduce yourselves, but if you could please write in through the chat box, just letting us know your name, your credential, and your location, just so we can keep a thorough attendance record. And then keep an eye on that chat box. I'll send something out at the end that'll be a link for you to claim a CME or CEU credit for today's session. And then feel free to use the chat box throughout to write in your questions or anything that you'd like to talk about. So we'll start off and we'll turn it over to Dr. Krasner to give us an update on COVID.
Well, this is our first Zoom presentation, so hopefully it works. And get this right. So this is the usual disclaimer. What's going on here? All right. Do not disclose all this stuff anyways. Today I'm going to talk about the COVID outbreak. That's on everybody's mind. You know, obviously there's been a lot of people stressed and panicky about this, and in my own practice, I can't think of anything like this. It brings me back to, you're old enough, you remember September 11th, the day after all the crashes, feel like the world had changed and was never going to go back, and almost that same sensation. There's a Dr. Anthony Fauci, we all know, the small guy next to Trump on the TV, and he mentioned, he said, you know, he was talking last night, and he said, you know, there's such a sense of panic and frustration and et cetera. And he says, yes, that's what we should try to do, is instead of just giving up, we should use that for, you know, for good, in terms of maybe worrying about your neighbor who may be elderly, may need help. Make sure your teenagers don't go out and party on their breaks, etc. So try to put some of that energy to help in this situation. So on this talk today, I just put it together every day and finished last night. I'm just going to talk about different topics that have come up about COVID, and see what we can talk about. Talk about why did somebody end up hospitalized, what the case fatality rate is, some data on pediatrics, talk about ACE inhibitors, etc., and take it from there. So I'm in Reno, and we've had, I think they reported about 20 reported cases positive, but nobody has so far been hospitalized with a positive COVID-19 test. And so a lot of the data I'm going to give you, at least clinically, is from physicians in China, and there's been quite a lot written by the hospitalist and intensivist in the Bay Area. They've had an outbreak, and in the Seattle area, giving their clinical acumen to help us guide us when we steer these patients. Let me get up to here. All right. So this is, you know, the big differential. Everybody's coughing, everybody's sneezing. How do you, at least in terms of patients that are sick enough to be hospitalized, how do you differentiate the cold, the flu versus the coronavirus? And what these physicians emphasize is that, you know, everybody knows what cold is. You're sneezing. Usually sneezing, stuffy nose, that is not part of the coronavirus presentation. So, and usually you don't have a fever. So nose, sneezing, coughing, congestion does not seem to fit with the coronavirus. So then the differential a lot of times is between the flu and the virus itself. And so if you've had the flu, most people say they feel like they got hit by a Mack truck, has a sudden onset, they have a headache, fever, and just feel horrible and say, why did I get a flu shot? In contrast, it seems that with the coronavirus, it's more of a subacute onset. Oftentimes, they don't say, oh, I just feel horrible, but it seems like they start off, their muscles may hurt, they may have a little bit of a cough, questionable fever. And, you know, in the old days, they would probably just say, just a virus. But it seems that, so the flu is a very acute onset. The fever, muscle aches, the headache, it's just, you know it, versus the coronavirus, maybe in retrospect, you know, I've not been feeling good the last few days. You have the myalgias, may have a cough, you have a fever, but it takes about a week for those who end up hospitalized before they really run into trouble. So there seems to be the acuity of the illness seems to be much more dramatic with the flu versus the coronavirus. And so the doctors in the Bay Area and Seattle talk about what their most common presentation of patients who end up hospitalized. And it's a 1 week, the prodrome of just feeling lousy, coughing, low-grade fevers. And then after about 7 or 8 days, they start noticing more trouble, not an acute onset. And so it takes on average about 8 days for these patients to really
Charlie, just a second. We're
short of breath. And 9 days to the onset of pneumonia. Stop your video.
Yeah, sorry, Charlie. We're starting to lose your audio. So if you could turn your video off, that'll help us speed up.
Turn off what?
I turned off your video, so that'll help with the audio issues we're having.
Okay.
Okay, go ahead.
Okay, so you were able to hear what I was just talked about or not?
No, could you repeat that, please?
All right. So you turned off the video, you're saying?
Yeah,
Ouch.
help speed up the audio issues that we're having. It'll speed up
Okay.
the connection. So go ahead.
All right, so as we talked about, the most common presentation of hospitalized patients, again, is this subacute onset, a week-long prodrome, as we talked about, subacute onset of myalgias, malaise, and cough, the fevers. And it isn't until about 7 to 8 days in that they start feeling a shorter breath. And then about 9 days when they start the onset of pneumonia. So it's really about a week gradual onset to about 7 to 8 days in when they start getting significantly ill. And we'll talk about the labs that you'll see with these patients, particularly the lymphopenia, the liver test abnormalities, and the abnormal chest x-ray, which seems to be pretty significantly correlated with the coronavirus infection. destroy. Okay. Give me just a second. All right, so these patients, the subacute onset, and when they talk about the labs that these patients have, the most consistent lab finding is lymphopenia. Oftentimes the neutrophil count and the total white count is normal, but you will see a significant lymphopenia, which is not something you'll normally see in patients like who have the flu and other viral infections. Oftentimes they have increased lymphocytes. So lymphopenia may be a point to look at. We had some patients admitted here with pneumonia, and they all had normal lymphocyte counts, and they turned out not to have the coronavirus. Another thing that we see oftentimes in the more ill patients is abnormal liver tests. Their AST and ALT are often in the 70 to 100 range, with higher numbers can be seen on the mid. And if they continue to rise, oftentimes correlate with somebody that's going to have a critical or fatal outcome. The other thing we find is a low procalcitonin. A low procalcitonin is very unusual in these patients. And if it's elevated, it may mean they have a superimposed bacterial pneumonia, which is apparently pretty unusual in these patients. So lymphopenia, abnormal transaminases, and a low procalcitonin in a hospitalized patient may make you very concerned about this infection. But they usually only have mild acute kidney injury. And on the next slide, this is looking at the lymphocyte counts. Your normal lymphocyte count is about 2,000 to 2,500. And on this slide, you see in the gray here, these are the lymphocyte counts of people who survived in the hospital days after onset of their illness. So after about 7 to 10 days, their lymphocyte count goes significantly down, about 500. But then after about a week or two, hold on a sec, after about 10 to 14 days, you see the lymphocyte count continues to rise nicely. In contrast, in the black line, you see that the patients who are admitted to the hospital and their lymphocyte count continues to drop are more likely to die. Okay, so the lymphocytes can be both an indication of the coronavirus infection, also a prognostic indicator, and this can be combined with abnormal liver tests and worsening x-rays. Okay, so the lymphopenia is a very helpful prognostic sign in patients admitted to the hospital. And so with the chest x-ray too, the findings may be subtle, but almost always present in ill patients. And the characteristic chest x-ray is bilateral patchy or reticular infiltrates, sometimes perihilar, so just sort of a ground glass appearance bilaterally. You're not going to see an effusion. So if you see an effusion on the x-ray, you may just be talking about another cause such as pneumonia or heart failure. And in China, they were using CAT scans to diagnose these patients. And they were saying almost every patient who was hospitalized had it infiltrated on the chest x-ray. They were doing about up to 200 CAT scans a day on one machine, per machine. However, in this country, that's not very realistic, given that you have to transport a patient in the full personal protective equipment and completely decontaminate the radiology room. So that's not something that we normally do. All right, so we're looking at abnormal transaminases, lymphopenia, infiltrates, are all very characteristic of this illness. And this is a x-ray of a typical patient with COVID-19. And you can see over here on the left side, this is the heart, these are the ribs, but you definitely see an infiltrate. That whitish infiltrate between the ribs there is a left-sided infiltrate. And again, on the right, it should be pretty clear, but when you get down here, again, you see bilateral interstitial infiltrate. So this is a non-specific but pretty classic finding in patients with this virus. Okay, so those were what we just talked about, were patients hospitalized. So there may be only the peak of the mountain of people with the infection, but they do seem to have the characteristics. So if you are admitting somebody to the hospital with clear chest x-ray, normal lymphocyte count, normal transaminases, it may not be COVID-virus, but if they do have these findings, I think it may be at the top of the list of things you want to check. So let's talk about the mortality, and we've seen reports all over the page from what percentage of patients with this infection actually go on to die. And this was from JAMA, and they had 44,000 cases that were from 500 Chinese hospitals, and they found a 2.3% mortality among symptomatic hospitalized patients. So 5% of the patients that were hospitalized had critical cases, meaning they had respiratory failure, shock, multi-organ failure. About 14% of these hospitalized patients needed oxygen supplementation and had infiltrates. But about 80% of these patients that were admitted had mild pneumonia and did well. So of these 44,000 patients which had PCR positive, they were diagnosed with the pneumonia, with the virus, they had a 2.3% mortality. But again, these were symptomatic hospitalized patients. So 2.3% of the patients were in the hospital died. But if you look at the bottom of this pyramid, this Y thing, there were cases, these were cases that were not identified. So you really don't, we know what the numerator were, how many people actually died, but the denominator is not clear because we have so many cases that were not identified. They just got over at home. They were not sick enough in the hospital. So I would say that 2.3% sounds like more. It's more of the patients in the hospital who get sick patients. So probably the real death rate is less than that. So let's look at this next case, which was the Diamond Princess, which was at the cruise ship that was anchored off of Japan. And as you remember, there was they were kept there for a week or two without getting off. And so they look at this, the scientists look at this as almost like a petri dish. You have 3,700 people locked up together for many days, and all of them were tested. So they didn't just test people that were coughing and sick, they checked everyone. And many of these that were on the ship, you know, these were old timers. So these were older patients than you normally see in the average population. So greater overall risk of dying. So this was very nice. We had wasn't good for them, but we basically had a group of 3,700 people all together, and we could see how many people were symptomatic, how many died, and get an idea of what the actual risk of dying was. So they had 3,700 passengers. They tested them all, and 619 or 16% of this group were infected. Were less than half. 301 of these 619 people that were actually tested positive, only about half of them had symptoms. And of these 619, 7 died. So among this older population in this laboratory setting on the boat, their case fatality was 1.1%. Okay, so if you got rid of those asymptomatic people, it would, and you only looked at those who were symptomatic, like in the Chinese study, you get a case fatality rate of about 2.2%, right? So this, if you got rid of the asymptomatics, which were not picked up in China, just the symptomatic hospitalization, again, you'd see 2.2% of patients that were symptomatic instead of the actual, which was 1.1. When you look at half the population didn't have it. So again, that suggests that the case fatality rate may be around 1% and not 2 or 3%. But if you look at, so let's compare it with the flu. The flu on the left over here, mortality rate is about 0.1% overall, but in the older populations, about 0.83%. So the flu is relatively, it's unpleasant, but it doesn't kill that many people, except those who are 65 with major underlying problems. In contrast, if you look at this virus, the coronavirus, when you get to 50 to 59, you go up to 1.3%. And when you get to 80, it's up to 14.8%. So the overall death rate is significantly greater. If you look at 65.83, if you look over here, 3.6%, 8%. So in the older population, the death rate is significantly higher in the older population. And overall, the virus seems to probably be about 5 to 10 times more likely to kill somebody than the flu does. Probably because we've all had flu vaccines, we've been exposed to the flu over years, and we have some degree of immunity to it. This virus is completely new to all of us, and so we don't have any underlying immunity, and you would expect it to be much more severe as it is. And so that was, so people will say what percent, but overall it seems probably around the 1% seems a reasonable guess, but particularly high in the older population. And one of the more interesting things that just come to light the last week is very interesting is on the surface of the virus, there's the receptors are called angiotensin converting enzyme 2 is a receptor that is used by the virus to enter the lung cells and the throat cells. So this receptor is the entrance site of the virus into the lungs and causes its damage. And this angiotensin converting enzyme 2 receptor is exactly the same one that are blocked by ACE inhibitors and ARB inhibitors when we treat people for hypertension. It turns out, I say, oh, that sounds good. Sounds like we'd actually be protecting people if we use ACE and ARB inhibitors. But what happens is when you block these receptors, the virus compensates, the lung cells compensate by actually upregulating the number of ACE2 inhibitors. And so by using ACE and ARB inhibitors, we're actually increasing the number of these receptors that are used by the virus to enter into the lung cells. And so this sounds concerning because we have so many people on ACE and ARB inhibitors. Are these patients actually doing worse in terms of mortality and critical illness than patients who are not on this? So a European study just came out this week that 99% of the fatal cases in some of these countries involve comorbidities. And this comorbidity, you say, oh, lung cancer, diabetes, COPD. Actually, 75% of these patients only had hypertension as their comorbidity. And as Dr. Fauci pointed out, if you are in a Western country and your blood pressure is under control, it's really not a major comorbidity. It's not like having diabetes or being immunosuppressed. So it seems like a tremendous amount of people who are dying have hypertension as their major risk factor. And so it seems very concerning. They didn't look at this study, didn't actually look at what medicines they're on, but as you know, ACE inhibitors are extremely commonly used in hypertension. And so they're going back to look at their data. So it does seem surprising that hypertension maybe is considered a comorbidity and increased for complications of this disease. And so they're definitely looking into this issue, but it is okay. So from old people, let's talk about children. And this was just published 2 days ago in Pediatrics. It was not published, but it will be published. And it was looking at kids. So they had epidemiological characteristics of 2,140 pediatric patients with the coronavirus in China. And we've always said that, oh, children are not so susceptible to it, but this raises a few red flags. And I'll show you the data, but their conclusion that children at all ages were susceptible to the virus, but no significant gender difference was found. So it didn't matter if they're a girl or boy. But clinical manifestations of pediatric patients were generally less severe than those of adult patients. So most of them tolerated it well. However, the one exception was that young children, particularly infants, were very vulnerable to the coronavirus infection. So this, if you look at this table here is like less than 1 year of age, and they had 379 kids who were diagnosed with the coronavirus. 7 of them were asymptomatic, 25 were mild, 127 were moderate. Severe, which is on a respirator, on high flow oxygen, and critical, where you have multi-organ failure, encephalopathy, was actually 33 plus 7 over 379. Over 11% of children under age 1 ended up having severe disease. If you contrast that, for example, age 11 to 15, they only had 3 kids with critical disease, and 14 was severe, even though there are 400 foreign cancers in the study. So it's 100 children who had it, 7 were underage in the study. So it definitely seems that children under age 1 greater risk for getting a complication of this disease. And in the older, once you get to 15, only 1 out of 335 kids over age 15 got sick, and only 9 out of 335 got even severe disease. So definitely, if you have kids at home or infants, you definitely want to make sure that pay extremely close attention to keeping everybody away from them. That's sort of very similar with pertussis. These children are not vaccinated, and these are the children that are most at risk. So pertussis, coronavirus, these are all things that are extremely important to protect young children. So, we have these guidelines for whom to test. The problem with that is we don't have any testing equipment. It's extremely difficult. They're running out of the Dacron swabs. They're running out of the viral medium, and we're ending up having to only test some sick patients. Unless you're an NBA basketball player, then you go to the front of the line. So the guidelines are interesting, but still make it very difficult because we really can't follow them because of the lack of testing available. So initially, priorities for testing were initially we wanted to do people within 14 days of symptom onset who had contact with a suspect or were able to confirm infection, or had a history of travel from Iran to South Korea to Japan to England to France to China. So those were the standard guidelines. But now we know that we're getting patients in the community who have no obvious exposure. So we call those community-acquired infections. And so the recommended guidelines now: any hospitalized patient who has signs and symptoms compatible should be checked. Maybe you don't think they have it, but it would be a disaster if they're in the ICU for a week and you didn't know and everybody's been exposed. So sick patients who have any compatibility with the virus should be tested. And particularly if you see lymphopenia, abnormal transaminases, and abnormal chest x-rays, which we talked about. And they also recommend that older patients, you have a patient with COPD, diabetes, who have mild symptoms, but will be very likely to run into trouble. You may want to get them tested as soon as you can. We have getting tested. We'll talk about that in a second. So this is the swab. It's a special swab that looks like a little bristle thing at the end. It's not a cotton one. It's not a Dacron swab. And at first we were doing 3 swabs. One was the back of the throat, one was sputum, and one was nasal pharynx. They have found out, and I'll show you the data, that the nasal pharynx is the only one you really need to do because it's the most sensitive test. And what you would do is you would take this swab. It has a thing where you can break it off there. You stick it far into their parallel to the septum and twirl it around, and then you take it out and you put it in this viral medium and break the end of it off and send it off. So the ability to no longer do 3 tests or even 2 tests has allowed some increase in testing, but we're still extremely short. And the reason that we only need the nasal pharynx, we don't need the oral pharynx. And this was a patient, a typical patient. So this is a nasal pharynx swab and an oral pharynx swab. And this is the PCR testing on the nasal, were both positive. And see, these things are called cycles. So it's how many times do you have to threshold and repeat the RNA, how many increase it before it becomes positive. So 18 to 20 for the oral pharynx and the nasal pharynx. So these are both positive. Day 7 of illness, again, they were both positive. It took a little bit longer on the oral pharynx, 30-time replication to make it positive. By day 11, they were still all positive, but day 12, the nasal pharynx remained positive, but the oral pharynx had now become negative. So the nasal pharynx done properly is a much more sensitive test than the oral pharynx. So the FDA this week dropped the requirement for the oral pharynx swab. And this is the serum is antibody. And so, not everybody has the coronavirus, and the protocol for patients who come to the emergency room or admitted to the hospital or ICU at Renown and other hospitals is that the first thing you want to do is a rapid influenza antigen test. Okay, that's a PCR test, or you can do the it's either an antigen test or the PCR test, which is more sensitive. And they also then do a viral respiratory pathogen test. So you'll get your influenza test, you'll be in isolation, you'll get an influenza test, you'll get a viral respiratory pathogen test. This is called a PCR test, but it looks for the RNA of all these different pathogens. You do see coronavirus, but those are the cold coronaviruses. That's not the COVID-19. And what we're seeing a lot of is influenza A, influenza B, parainfluenza, and we're having an outbreak of something called human metapneumonia virus, which is just a virus which causes influenza and pneumonia-like illness. But this has been very reassuring that we get these patients detected. If both these tests are negative, then they are proceeding with the COVID-19 test. These can take just an hour or two to get done. The COVID-19 depends on 6 hours to 6 days to get it done. But at least this way, we have an answer very quickly if we can take him out of isolation or just treat him for the flu. And so this is, I work at the VA. And so this is, should you be doing this in your office? Absolutely not, okay? First of all, you should not be evaluate anybody for this in your office. You must, here in Reno, if we have anybody we're suspicious for, we have them call the Washoe County Health Department, and there's a line, and they will take your number and they will talk to you and see whether or not you're appropriate to get tested through one of the drive-through things. If somebody's sick, then you will direct them to the ER and let the ER know that you have a COVID-19 rule out. But this is not something you should be doing in your office, or because you don't have the personal protective equipment to do it, okay? You absolutely need a mask and the gowns and the goggles. But this is a nice way. The question is, what do you need? Because we have such a shortage of particularly N95s. What should you do? If you're proximity to the patient, if you're greater than 6 feet away, and the patient is wearing a mask, you do not need a face mask or respirator, but I certainly would. If the patient is masked and you are 3 to 6 foot away, you should be wearing a mask, okay? Because it's aerosolized and goes to about 3 to 6 feet. If you're less than 3 feet away and the patient is masked, you should be wearing an N95 mask or a PAPR. And in room during aerosolized generating procedures, like you might do in an ICU, definitely need to be wearing an N95 or a PAPR, okay? So if the patient's masked, more than 6 feet away, you don't need a face mask, as long as the patient's wearing a mask. 3 to 6 feet, both should be wearing a mask. Less than 3 feet, you wearing a mask, and patients wearing a mask, and you should wearing the N95. But don't do this in your office. And so this was the critical role of N95 mask in the management of these patients. And this just came out from China. And they looked at what incidents of healthcare workers, because in this hospital, 1/3 of their patients turned out to be infected medical providers. And they looked at how important was wearing an N95 mask in protecting the physician and the nurses. So this one group had N95 group, so they're wearing the N95 respirators. Hold on. They had a lot of patient exposure. They had 278 doctors and nurses who were all wearing the N95 mask. None of them got infected, which is fantastic. They had a no mask group. Either they didn't have masks or they didn't wear them. And these healthcare workers were disinfecting and cleaning their hands occasionally. So 10 out of 213 doctors and nurses became infected. So highly significant, P to a million was positive. So the N95 mask really seems to be a critical part of your personal protective equipment. And as you know, we have a great shortage. They're either being stolen or we don't have a supply of them. So if you're going to be dealing with these patients, you definitely want, and taking samples, you definitely want to wear an N95 mask. But that's really nice to see, is that if you're using proper protection, at least in this group, not a single one developed the virus. And so you want to get yourself tested properly too for that N95 mask. Again, that's not something you're going to do in your office. And again, you may have heard Governor Sisolak 2 days ago, where he was talking about trying to reduce the incidence in our state and protect those most likely to experience severe symptoms, such as older Nevadans. And obviously, we should add babies less than a year old should definitely be protected, and those with underlying chronic conditions. Preserve and protect our healthcare system, including our healthcare workforce, so that they can care for the least healthy individuals in the community, and minimize the social and economic impacts. So everybody talks about social distancing, and what's the evidence for that? So this is a very interesting, this is actually the first time social distancing was used in the 1918 flu death outbreak, which 50 million people died. And they actually had a nice randomized study here. And so they had 2 cities, one was Philadelphia, the other was St. Louis. And each city took a different approach to the flu. So for example, if we look at the red here, in 1918, the first case in Philadelphia was seen September 17th. And it wasn't until the cases started rising on October 3rd that they had people isolate themselves and social distancing, but it was way too late. And they got a massive increase in the death rate per 100,000 people. And so it was too late. The intervention was too late at that time. In contrast, St. Louis down here, their first case by things stayed home, and you see a remarkable leveling off of the peak incidence. They may have had a lot of deaths, but at least their whatever medical system they had wasn't overwhelmed by the system. And so this is exactly what we're talking about with social distancing now, is trying to smooth this out so we don't get this amazing jump that they're seeing in countries like Iran and Italy. And I'm afraid, I suspect, we're probably here when we started doing this. And it was because we didn't have the testing going on. So I think this is probably, this is what Dr. Fauci is expecting, that this is what we're headed toward, and not what places like Singapore, which was really aggressive about distancing people and isolating them. And so this is the whole concept about social distancing, because this is maybe what we have in terms of ventilators and physicians, but this is what we're headed towards. And this is probably gonna be the next week or so. And just you won't be involved in taking care of patients in the hospital, but there's a drug called remdesivir, which was made by Gilead, and it's an RNA polymerase inhibitor. Basically, it blocks the virus from replicating. They had developed it for Ebola, showed to be effective, and it also worked in SARS, but those diseases went away so quickly there was really no use for it. But right now, there's an expanded access program where you can request it. It takes it, but these patients have to be extremely sick because it's such a shortage of drug. They have to be on respirators, on pressors. They have to have very transaminases can't be too elevated. They have to be creatinine clearance. But the initial reports look like it's probably going to be very helpful. So this is probably our best hope in terms of treatment for our critically ill patients, and then maybe 12 to 18 months later for a vaccine. All right, so last night, Dr. Fauci was interviewed on the JAMA network, and just an amazing man. But he said he's seen a lot of epidemics, but nothing like this before. And he says, try to channel some of your panic and fear to try to something positive, and just taking care of patients, taking care of your neighbors, maybe not hoarding your food, and really protecting the vulnerable, making sure that no one's visiting them. And the other thing is he focused in on kids. He said, the teenagers don't get sick, But if you look at countries like Korea, the majority of people actually infected were teenagers. They didn't get sick, but then they were spreading the disease to the olders. And so a lot of things we can try to make positive during this time. He talked about, there was a study, he says people are scared of getting packages shipped from China, but they did a viability on hard surface study, and it only seems like the virus is good for about 1 to 2 days, so it's okay to open your Amazon packages. The other question is, he was talking about healthcare workers. He says we're going to run out of healthcare workers. We have to wait 2 weeks after they get infected, make sure they're asymptomatic with 2 negative PCR tests. He says we may be looking at just a few days after resolution of the symptoms to allow them to turn to work quickly. Another thing he talked about was non-steroidals. There was this big thing about not taking ibuprofen. And he talked about how aspirin and children with the flu can lead to Rye syndrome, which is very severe. But he says non-steroidals are not aspirin. We're not dealing with the flu. And he's not really sure that it's going to be significant. He says, but if you have a fever, take Tylenol. And he commented that he saw the increase of 500 to 700, 900 cases reported the last 3 days, despite a shortage of things. And he says, likely we'll know before the end of this month to what extent this epidemic is going to fully affect the medical capabilities of this country, just like we saw in that slide with Philadelphia. And he just says, you need to emphasize to young people their obligation to look out for the more vulnerable people. And redirect the panic energy that we are all feeling to actually do something to mitigate the disease, social distancing, staying home, etc. So it's pretty scary business, and but I think it was interesting, at least learning the last day about the pediatrics being very protective of that child up to 1 year of age, and looking at lymphocyte counts, viral transaminases, and X-rays. And don't do this at home. Don't do your testing at home. Well, thank you. Any comments or questions?
Great. Thank you so much, Dr. Krasner.
All right.
Thanks.
Thank you all.
Any other questions or comments before we wrap up today?
Thank you all.
All right. So thank you so much, everybody. This was a great session today. Hopefully it helped you understand things a little bit better. So this is probably going to be our topic for next month as well. We're just going to keep this going, trying to support you. So I sent that in through the chat box Thursday, April 16th at 12:15. So hope you'll join us then. I also did send out the link for the CME evaluation if you need to claim credit, and then a link for you to sign up for our mailing list if you want to receive weekly announcements about what other echoes we've got going on. And then just keep an eye on our website. I'll post those other resources out there today. Thanks, everybody. Take care.